During the first joint advanced seminar of their Carter journey, the PhD fellows travel out of the city to engage with public health research and delivery, in practice, in the field.
Okay, so you are most welcome to Iganga district and particularly to Makerere University Center for Health and Population Research, where we mainly do community-based research, but at the same time we support graduate research training. To see that graduate research is not just done to complete a degree, it's not just done to graduate and the student goes away, but it should be able to answer pertinent questions which are supposed to influence decision makers.
A field visit can give fellows insight into the logistics of how to do research, how long an interview can take, how to ensure confidentiality and informed consent, and how quality control in data collection is assured.
I'm imagining that you did not come here for a lecture, is what I'm imagining. I hope that assumption is right. But we wanted to show you some of the tools we use. The community reporters, we give them, these are lab people, like the VHTs. The VHTs, we give them this local story, this book, it's a small page. These are simple forms which are filled in by a village resident, which only asks a simple question. What event has occurred in your village? Then they will tell us, 1, there is a birth. 2, there is a death. If it's a death, we ask who has died, from whose home. Was it a male or a female? That is the key information.
I was able to learn about the HDSS generally, and then the way they operate, because I was always puzzled as to how they organize the surveillance, demographic surveillance, and then year in, year out, because this has been on for about 15 years now. And I think I had some insights into that, and the use of community volunteers, reporters, to get information real time as much as possible.
When we receive it, then this team takes over. They go into our database to check, has the person who has died present in our database? If he's present, then we look out for the unique ID, because every individual has a unique number. Then we know we need to go to the home and schedule a visit and interview, get details about why has this person died, and details of that.
I could see the articulated, systematic way data is being collected from in the facility. And then when the man was speaking, he talked about how they make sure that every person has an identifying number. That's like an identifier. It was quite interesting for me, given the fact also that there's a pilot community where they take data from. They are consistently taking data and then updating.
A field visit like this one can illustrate how health systems work, or how a health system works with others to improve access to care.
When she reaches home,
So she first asks the mother whether she's pregnant or not. So that is after she introduces herself and why she's in that household at that point in time. Then she requests them to talk to her. She only starts if they accept or give consent for her to proceed. The DSS taught them all this material. So they became ambassadors. They came back to the village level and started supporting women.
For them to be here, it means that at least these women have people that are closer to them. They relate with them not just as professionals in quotes, but also as friends, because over the years they must have gained the confidence of these women. So sometimes even the women would also, beyond assessing healthcare, would also maybe emotionally onboarding some things. And so I think they are very vital presence in this community. I think we've gone beyond having things in bits and pieces. Now we are all looking at how do we integrate systems to make efficient delivery, especially for healthcare.
So, given that what they do in the community, especially training people, and do you already document that and see whether, given the time that you have been following up this village, do you see changes like the mortality rate for infants, neonates, maternal?
In 2007, 2008, by that time we realized that in every 100 people who were dying, 40 of them were children under 5. 2008-9, there was a PhD student who came in, like you, tried to find out what exactly is causing this. They found that the causes of death at that time were preventable. The major cause of death was in under 5 was malaria. However, we are close to facilities. The government procures and invests much in anti-malarials. So what was the reason? What was the cause? What was the problem? Where was the gap? In trying to investigate that, one student focused on how are the pregnancies taken care of, right from their journey to delivery. Another one focused on how do we improve care of the newborns when the child is within the hands of the mothers. That is, out of that research is the outcome which she talked about, the kangaroo mother care, and which later on became a national policy where facilities have to have a neonatal care unit in Uganda.
It was very clear that intervention using community health workers as community distributors of antibiotics and anti-malaria really was effective. So it shows that having a community-based intervention and being able to monitor within the community real time is very good. It's synergistic. Unlike waiting for government records that are routine at health facility, you won't get anything much. But in real time, over the years, they're able to observe the trend coming down as regards child mortality. And that could be tied to the interventions that was put in place. I think it's something that is practical and makes real sense to me.
I am a malaria person, so it's kind of made me see that there's also a link they could feel, especially when we're talking about the residual malaria transmission stuff in Africa.
So we also believe that as you're pursuing your third degrees, the research we are going to undertake or you are undertaking is answering questions which are supposed to improve the quality of life of the people.